And here we are again with another very important conversation about the menopause and osteoporosis. So just to frame this, I'm absolutely delighted that Dr. Sandra can meet us again this evening and chat with us and have a bit of a mini series really of certain topics to help dive a little bit deeper into areas like osteoporosis, as we mentioned before, heart disease or brain health, all of the really important things that we need to be paying attention to. And starting this evening with osteoporosis. So let me open the waiting room so everybody can come in. So Dr. Sandra, thank you so much for coming along. How are you doing?
I'm okay. I had a surgery this evening. That's why I did run back.
Oh, you're so busy. Well, I'm sure that we can get this done in a good amount of time now, that we don't keep you here too long and you can go and relax for the rest of the evening then. Thank you so much. So the menopause and osteoporosis, and also I did ask a question the other day because I don't know whether it's just that I'm seeing a lot more and very interested in learning a lot more about the menopause now, but I'm also seeing it in the press. And there was, I saw on social media as well, some conversations going on about the amount being prescribed to some ladies above what is recommended. So what are your thoughts on that, on what's been out recently?
Well, it is a complicated subject, and menopause is a very individualized situation. So there are different kind of hormones in different kind of chemical compositions and different doses. You can't really tell what dose a woman is going to settle on. You can't really tell how a woman is going to react to this particular chemical composition. You may have to change it to find a different one. So to be honest, the recommended dose, what the papers are, the Daily Mail basically is referring to, it isn't exactly a recommended dose. It's just that those are available, the doses out there.
Yeah.
So you have got like estrogen. You need your estrogen. If you have your because in menopause that is the main thing we're lacking.
Yeah.
A woman is lacking estrogen. But you can't just give estrogen, because if you just give estrogen, it makes your lining of the womb very, very thick. And that make you prone to a cancer. So we have to give progesterone as well.
Yeah.
And the estrogen and the progesterone together will stop you having the menopause symptoms, stop you having menopause consequences. And the progesterone will prevent your lining of the womb so you don't have a cancer.
Yeah.
And there are patches out there with a ready-made combination of estrogen and progesterone. And the highest dose of patch that is available out there is with the estrogen 100. And they have calculated the amount of progesterone that would sufficiently line your uterus with that progesterone.
Right.
So that is like the highest dose available out there in combination, where somebody can safely say like this amount of estrogen and this amount of progesterone is safe.
Right.
If you go beyond that, nobody has said that you can't go beyond that. You can go beyond that. It just, you have to keep it in mind as to like, okay, I'm up in the estrogen now, so I should be up in the progesterone as well. So that's all there is to it. And just to make matters a little bit more difficult, there hasn't been any proper study that would actually tell you what is the what would you consider as the high dose of estrogen.
Right.
Some doctors would consider 50 high enough. Anything above 50, they would go and increase the dose of progesterone. Some doctors would consider 100 high enough. Anything above 100, they will go and increase the progesterone. So, and whether a woman need more estrogen depends on symptoms. And to make sure that we're not overloading somebody, we sometimes do blood tests as well. And I would usually do both. If somebody is on like 100, and if they're telling me that my symptoms are still there, I think I need a higher dose. In that case, I would do a blood test as well, just to make sure that their estrogen level in the blood is not too much.
Yeah.
You can't decide just with one. You usually do two to try and get the best kind of dose for your patient. But you have to bear in mind that if you are coming up to high doses, you need your progesterone on the high dose as well.
Yeah.
Then I would usually explain to my patient as in, okay, your estrogen dose is pretty high, which means that we have to increase your progesterone dose. Progesterone has side effects. It can give you like bloating, it can give you mood changes, it can give you constipation. So I would explain it all to the patient, and then they can choose like, I would try the higher dose of progesterone, see if I tolerate it, or I don't want to do higher progesterone. In that case, I would encourage not to increase the estrogen.
Yeah.
So it's basically a conversation between a woman and a doctor, depending on their individual situation.
Of course.
So when people say recommended dose, it's actually very general.
Yeah.
We have, ever since this article come out, we have been having discussions in the doctors among the menopause groups, and everybody is like, well, there is no recommended one, as in like you can't go beyond that. You can go beyond that as long as you have got sufficient evidence to support your decision.
Yeah.
But if you do go beyond that, you need to make sure your patient understand the side effects of high estrogen, and how you would need the high progesterone to go with it, and the side effect of high progesterone. As long as everybody knows what they are doing.
Yeah.
It.
Yeah. Of course. That's thank you so much for explaining that, because I think from seeing that you feel like, oh, this is great advice that I'm getting. Then you see somebody else then arguing, and you're like, oh my gosh, what do I listen to now? And it's so important, isn't it? So it is something that we could feel really confused by then. So thank you so much for clearing that up. I think that really does kind of explain how complex all of this is as well. It's never going to be the same for everybody. We're all very wonderful and unique, and we do have to approach everything with that kind of individualized approach as well. And
So
yeah.
I would say, as a rule of thumb, if you don't know whether you are on a high dose or not, if your doctor says like, oh, your patch is not coming up in anything higher than that, we might have to add in like a gel to increase your dose. That usually means like you probably gone up to as high as a patch can offer.
Yeah.
And most of the time the patches are like combined. So if you come to that sort of a stage, you some bells should ring in your head, as in like, okay, is my estrogen pretty high now? If my estrogen is high, should I be upping my progesterone?
Yeah, yeah, of course. Oh, lovely. Thank you so much for sharing that with us. So on to tonight's topic then, the menopause and bone health, osteoporosis. So enlighten us the importance really of looking after our bones, why this effect happens, and what we can be doing to reduce the risks of osteoporosis and the risks that come with it.
Osteoporosis is one of the reasons that a woman would go on to hormone replacement therapy.
Yeah.
Because a lot of women might say like, I went into menopause very early, but I tried to persevere with the symptoms, and I didn't take the HRT, and now I'm out of the menopause. Now I'm okay. The symptoms are not the only reason that you might want the hormone replacement therapy, because in every woman, pretty much every cell in our body has got an estrogen dependent function. They do something. And the bone growth is also maintained by the estrogen in your body. And when you come into about like perimenopause, menopause, your estrogen levels start to go down, and that affects your bone turnover. The bone is like your skin. We're always shedding the old skin, and we're always putting a new skin in. So when you were having enough estrogen, your balance of shedding out the old bone, breaking down of the old bone, and laying the new bone is quite balanced. You're doing it at the right time for both processes. And then when you come into menopause, estrogen goes down. So your bone breakdown is a little bit quicker, and the new bone lay down is a bit slower. So you end up with a bone which is like an old chocolate, like a bit brittle and not very connected inside.
Yeah.
That sort of hollow, brittle kind of bone.
Yeah,
So
I remember seeing it when I was in uni.
yeah.
It was like crunchies or arrows or something, that they're
Yeah.
very like lots going on the inside there.
Yeah, that could be very tight before.
Yeah.
And then because your new bone formation is slow and the old bone breakdown is quick, it become like that.
Yeah.
And then it makes it easier for you to break.
Yeah.
So the studies have shown like over the age of 50, about 1 in 2 women will have osteoporosis, and about 1 in 3 may have had a fracture.
Yeah.
And the fractures basically limit your life.
Yeah.
And some fractures can even be life-threatening. Like if you fracture your hip, you lose a lot of blood, and that can be quite life-threatening.
Yeah.
And that would put you in bed. That would have like side effects of pneumonias and blood clots and all that. So to prevent that, you would like to look after your bone before this happens. So like I said, osteoporosis is basically the balance between the bone breakdown and the new bone lay down become off balance. You can't do a lot with the bone breakdown, but you can help yourself with the new bone laying. For that, you're going to need things like calcium. You need vitamin D. So calcium, vitamin D. From the diet, you can have the calcium from milk mainly. And the vitamin D you can also have from like little tin fish, little fish with bones.
Yeah.
The one that you can eat. And sunlight, we don't have that much of sunlight. So if you want to make it easier, if you want to just take a calcium vitamin D tablet, you can. But the idea is to have enough calcium and vitamin D to increase the lay down of the new bone. And the other thing is to reduce the breakdown, to increase the resistance. You would want to increase the weight-bearing kind of exercise that you do. So the weight-bearing exercise basically means that you need to be standing up. So things like walking, running, and the other kind of exercise that you want to do is some repetition, so that you put a bit more of resistance on your vertebra. So that's your part. You can explain a bit more on that.
Yeah.
So weight-bearing exercise, diet, sunlight, calcium, vitamin D, those are the kind of things that you can do. But on the other hand, if you are low in estrogen, the only way you're going to get it back is taking the estrogen in one way or the other. If you are somebody who can take HRT, you would have it from HRT. If you can't, there are some diet which are rich in estrogen. You could try them. They're not going to be as high as the hormone replacement therapy, but you could still try. Things like soya, those sort of things would help.
Yeah. Yeah. Fabulous. Excellent. So we can see that a combination of seeking help and getting the hormone replacement, plus our lifestyle, our daily habits. And it certainly takes, I mean, I work with women. Initially, they'll come to me because they want to lose weight. 99.9% of them are, and they may be still looking at exercise and nutrition as what can I do to eat less, exercise more, to get toned, to it's great for our mental health, of course, but to be toned and defined. But what this does is it just heightens the importance of looking after ourselves, that this goes far beyond, wanting to get into that size, whatever dress, but into being as healthy and well for as long as possible, and really looking at the importance of, exercise for our health, not just to get toned, and great nutrition for what's going on inside that we can't see. And I think that's what's really important about what you mentioned there about HRT and, surviving the symptoms and feeling defeated when people end up going on HRT then, because again, there's a lot of stuff going on inside that aren't on the surface. So beyond the symptoms there. And I think that Janet has got quite a valid point here, because Janet didn't have HRT. She said she wouldn't have been given any. So now that she's out of the menopause, what should she be taking or maybe doing to protect herself, because she hasn't had HRT then and didn't really have any symptoms either?
Well, the one thing about osteoporosis is that once you have osteoporosis set in you, you're very easy to break a bone.
Yeah.
So if you haven't broken a bone until now, there's a pretty good chance that you haven't had osteoporosis yet.
Yeah.
So you could still be doing the diet and lifestyle. And depending on where your menopause, where you are in menopause, you can still think about HRT, because if you are in the first 10 years of menopause, we would say that taking HRT for prevention purpose is still worth it. After the first 10 years though, the damage would have been done. So I wouldn't give anybody after the 10 years of menopause and HRT for that purpose. I would give them if they are still symptomatic and if they want to have some symptom relief. But in the first 10 years, taking the HRT would prevent you from having osteoporosis, and it is also used as a treatment for osteoporosis as well for a menopausal woman who has broken a bone. And it would help with your the heart health. So a lot of things haven't been already broken down in the first 10 years. So it would be good if you are still in the first 10 years and if you want to take HRT for those purposes, you can.
Yeah.
Otherwise, if you are out of those 10 years and if you don't have any symptoms, you just want to look after your bones, just go with phytoestrogen is what they call for the estrogen in food. So
Yes.
the food is rich in estrogen, and then you do weight-bearing exercise, calcium, vitamin D.
Yeah. So all of the lifestyle factors that we talk about, and these are the things that are in our control then, like you say, the phytoestrogens in certain foods, the soya products, tofus, and, like I mentioned before, the Japanese style foods that are very high in soy products there, and the resistance training, which I know the girls are all doing, lifting weights and doing that body weight stuff. So this is where the lifestyle stuff is very important. Is another question, I'm not able to take estrogen. Would that put me at a higher risk of osteoporosis?
It depends on why you are not able to take estrogen as well. In general, though, yes, it's not just you, though. Any woman after menopause is at high risk of osteoporosis.
Yeah.
Because the estrogen was quite important in this bone turnover process.
Yeah. 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 Okay. And again, maybe something to speak with a GP about then on that individual case, is it?
Yeah.
Okay. And there's another question as well that I'm going to, and I think that this would be quite common as well. What can help with aches and pains in the hips particularly? Because aches and pains, I don't know if I read that properly then, aches and pains are quite common, aren't they, to be experiencing?
Well, aches and pains, that could mean two different things. One is like arthritis. Anybody will have arthritis, man or woman, basically anyone will have arthritis as you get older. It is general wear and tear. It's just part of the aging process. Our bones have got there's a bone in a joint, and then there is a cartilage in between.
Yeah.
So, and there is some lubricating fluid around it. So you glide easy.
Yeah.
As we get older, the cartilage becomes thinner and thinner, and the lubricant become less and less. So you're eventually starting to grate bone on bone.
Mm.
And that would mean it hurts because the bones are pulled by the muscles a bit more. So the pain is from the muscle pulling, also the grating. And because it's not as lubricated as it was before, it become a bit stiff as well. So all of that will be osteoarthritis, and that can be helped by any painkillers, but we normally advise people not to rely on painkillers so much for osteoarthritis. Some people get confused between osteoarthritis and osteoporosis. Osteoporosis, unless it comes to like a pretty late degree, or unless you got like a pretty low vitamin D, it doesn't give you that much pain. Osteoarthritis, on the other hand, will give you pain
Yeah.
because your bone just doesn't glide as good as it used to. So any painkiller like a paracetamol is fine because it doesn't have a lot of pressure on your kidney or your liver or your stomach. Things like ibuprofen will be better in pain relief, but if you take them long enough, you will have side effects on your stomachs, on your kidney.
Yeah.
And osteoarthritis is not something that goes away.
Yeah.
It is something that will stay with you, and all you can do is to try and maintain it at a low level. To maintain it at a low level, you want a balance between the rest and exercise. If you rest it too much, it'll become too stiff and too painful. If you do too much, it will become painful.
Yeah.
So regular exercise, a moderate degree, that will help. And some things like okra, lady's finger,
Yeah.
it has got this gelatinous kind of gluey substance in it.
Okay, I didn't know that.
That actually helps with the lubricating fluid in the joints.
Oh,
So
interesting.
useful. And also glucosamine chondroitin, which you can get from the places like Holland and Barrett.
Yeah.
It helps. So they don't help with the pain directly, but they actually help with the gliding movement.
Yeah.
And then
Excellent.
when it glides easier, your muscles will pull less, and then in a general as a whole, you will have less pain. Combine that with your regular moderate level exercise, you could live with arthritis pretty well.
Yeah.
And if it does get worse as you get older, but it's a very, very slow process.
Yeah. 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 Oh, thanks for that. And the power of great nutrition again on that one. I'm going to ask the last one. I know Michelle has asked about should we take vitamin D if on HRT or not needed? Yes, take it anyway. It's going to be important for all sorts of things, your immune system and that there. I know we're not talking about perimenopause, but I've had 2 blood tests. My levels have been normal both times. I've had them 3 months apart. Could I still be perimenopausal if my levels have been normal?
Yes, because normally the British Menopause Society or any guideline wouldn't recommend doing blood tests for perimenopause anyway,
Yeah.
because around perimenopause your levels can go up and down. So that the diagnosis is basically if you are somebody over between the age of 40 to 51, 55, and if you are having symptoms, that's perimenopausal.
Yeah.
If you're somebody younger than the 40 and if you're having symptoms, so we do bloods, not to diagnose the perimenopause, to actually diagnose any other condition that might be giving you symptoms. So the blood test for perimenopause isn't really reliable, so we don't do it. And the main way to diagnose is your age. Anybody over the age of 40 and having symptoms are very likely to be perimenopause.
Yeah, yeah. So maybe a trip back to the GP and say about these symptoms then, maybe for
There
Claire.
is a scale called Green Climatric Scale,
Okay.
menopause symptom scale, and you can download that on Google. Well, it is pretty easily available. It's on my website as well.
Brilliant.
So just have a little look and try and fill it in and see how many boxes you tick. If you are ticking all of those boxes, and if you are over the age of 40 something, it's very likely perimenopausal.
Yeah, yeah, excellent. Thank you so much. A very useful link for us to be looking for, and certainly get onto your website for that. So that's going to bring us to the end of this conversation. Thank you so much. But before you go, would you remind everybody how they can find you, what your website is, and of course to be getting these useful resources and to also consider the clinics that you offer as well?
I work for the NHS in SA1, and I also do private practice in Santa Maria. Santa Maria is on Friday evenings 5 to 7, and I also do clinics in 1192, which is in Swansea, is for Saturday mornings. I work for IGP as well. Is Friday mornings are remote, and I also do clinics for IGP for coil insertions and implants, etc.
Excellent.
I see, like somebody saying, it's always the hips. Well, it depends on which joint you use more in your life. That would be the first joint that would start getting the arthritis. So in these days, you might actually start having arthritis in your fingers if you were somebody who does a lot of office job. If you type a lot, that might be the place where you start having arthritis. If somebody is like more of a person who walk all the time, it will be the knee. Hips
Right.
usually are actually some sort of a medium duration, but the hips actually the hips support you for whole upper part of the body. So housework and stuff would involve a lot of hips. So if you do a lot of housework, you might start noticing the hips are the problem.
Yeah. Yeah.
Oh, there was one thing I was going to say, I forgot. The osteoarthritis gives you pain and stiffness,
Yeah.
but it does get better as you move about.
Yeah.
And with the menopause, though, you can have muscle aches and pains and the stiffness in the joints. That can happen without the arthritis. It just happened because your estrogen is low, and sometimes it's because of the testosterone as well. So that sort of aches and pain will go with HRT.
Yeah.
Osteoarthritis will not go, the pain from osteoarthritis will not go with HRT.
Right. Okie dokie. That's lovely. Thank you so much for that. Well, another brilliant conversation. Really appreciate your time. I know you've been super duper busy, so we'll let you go free now and look forward to the next conversation on the next topic, and we'll catch up again there. So girlies, I hope this has been very helpful for you this evening. And thanks again for spending the time to share this, not just with the Life Transformer girlies now, but with everybody that will be listening to the podcast and also following you on your social media as well. So thank you so much.